talk about anatomical challenges of dental implant. That's why we need a lot of surgical guide. So there are many anatomical challenges in dental implant. So in the anterior, we have the location, because it's very limited space, and angulation. So you need a surgical guide to do angulation. Also, the buccal plate is very thin. You don't want to break the buccal plate. In the lower, we have lingual plate, very thin. In the premolar and molar area, in the upper, we have the sinus. The sinus is a big deal because the sinus grows with age. And I don't think really it's coming. The sinus will grow with age. So when you erect, the sinus is small. And the other thing with the sinus, when you extract the teeth, it will grow to the space. So it would make our job more difficult. And that's why we need more surgical sinus lift, sinus fill, avoiding the sinus. And sometimes they go pass through the sinus, go to the zygomatic. Have you heard of the zygomatic implant? Will go through the sinus. And sometimes I've seen cases, the implant in the sinus, and there's no complaint. And sometimes people, when they extract the tooth, they leave a fragment in the sinus, and the sinus no problem. But sometimes they get infected, they get problems, and sometimes when they do try to remove the root to make more damage. Yeah, anyway. In the lower premolar and molar area, we have the inferior alveolar nerve. And the canal with it's pretty small, has a nerve, an artery, and vein, and lymphatic vessel too. In the lower anterior, we have a strong bone, but it has limited space. That's another limitation. So these, the anatomical limitation. We have the greater palatine artery, nasal, narrow ridge in the interior. We have the sinus, nasopalatine area, foramen. Lower, we have the inferior alveolar nerve and the mental foramen. These things. So the trigeminal nerves, they call it trigeminal because it has three branches. One go to the eyes, we call ophthalmic. One go to the maxilla, we call maxillary, and the one go to the mandible, called mandibular. The mandibular is not only sensory, it has a motor. The motor goes to the muscle of mastication, and the sensory branch goes supply the face here, supply the teeth, and one goes inside the mandible. That's why the dentist, when they do block, they inject. They have to find the inferior alveolar nerve before it goes inside the mandible. They block it, and the end of it will the mental, so it will supply the lip. So every time they do, the dentist asks you, "Is your lip numb?" Mean the whole nerve is numb. So this is the hole here. The nerve is number C. It's not underneath immediately. So some people, they think it's like when they go to the hole, they reach to the nerve. No. Sometimes you damage, but sometimes from the inflammation can damage to the nerve. There's a vein, an artery, and lymphatic tissue. And another thing, the size of it is about 3 to 4 millimeter. Inferior alveolar nerve about 2 millimeter away. And so when you drill, you have to feel. When you drill with osteotomy, when you try to get implant, you feel it. You feel the bone thickness, a little bit thickness, because it's thickened, then there's no bone at all. So when you feel there's thickness, you should stop. Anyway, so the X-ray, brevical X-ray, remember brevical X-ray really sometimes shows them that show it, sometimes it doesn't. While panoramic and CT scan, CBCT can show it. You don't want to end up with this, especially the premolar area and molars. It's very painful, and you end up numbness here and this area, whether permanent, temporary. Most likely it's temporary, but sometimes permanent. It's very bad for your patient, for reputation. So now you need the surgical guide. Surgical guide not only give you location, orientation, can depth too. so you can make the you put color on the drill. When it reaches certain depth, it will stop, and the surgical guide can guide you for that too. Another thing with the inferior alveolar nerve, it's before it goes out from the mental foramen, it's a branch. One branch goes still in the bone, supply the anterior teeth, and one goes out, supply the lip. That's the branch. In embryology, that's where the source where the mandible grow. There's a cartilage, Meckel's cartilage. That's on that branch between two of these branches. That's the mandible grow. And different people have different location of the mandible. So we have to know the Chinese and Nigerians, they have a different location of the mental foramen. So, but most likely, you don't go by statistic, go by X-ray. Take X-ray and see. And the other thing, the nerve will take a curve before getting out of this mental foramen. That's the worst thing, because usually the premolar area, first premolar, here. So when you do implant, especially if you have edentulous, complete edentulous, and you want to put 4 implants in the lower, you should choose the canine area, but sometimes the canine is not available because they want to put a little lateral to here and more the incisor, lateral incisor, and to the premolar. But you have to be careful with the curvature of the mental foramen and mental nerve to sometimes include that. Another thing with the edentulous, like this is newly extracted teeth, we have enough bone. With age, the bone shrinks, and imagine the foramen will be under the mucosa. There's no bone at all. And when you do incision, well, in the book he said, go lingually. Your incision gonna be not on the cheek side, on the lingual side, on the tongue side. Another thing, in the lower we have very large artery. Remember I was talking about the maxillary artery, very large, giant artery. We have, at the time, we have very large artery. We call it lingual artery, sublingual artery. So you have to take X-ray, you have to find it, and avoid, you can use surgical guide, and you have experience and study the case before you do it. Because sometimes, this is when you do without surgical guide. You go on the lingual side and you break the buccal lingual plate. This is lingual plate, and the whole implant and drill fracture is going to be like that. This is part of the muscle, Malahan muscle. Imagine the pain and the bleeding and stuff when you remove this.
Yeah.
Yeah. So this is the inferior sublingual artery. It's very rare to injure the sublingual artery, but you don't want to see the bleeding. You're not going to stop it. Very difficult. And anyway, you don't want to perforate the sublingual artery. In the maxillary, imagine these anterior teeth. Here, the third molar. Behind third molars, we have 2 nerves. One nerve and artery and vein, they are come bundled. One goes anteriorly, we call it greater than that. It's really great, big. And one here, go posterior, we go to the soft bud, we call it, that's greater, lesser. Yeah. So this is lesser than a time. This is lesser than a time. So the greater than a time here, this is lesser than a time. We never care about this, lesser than a time, because when you do implant, unless we do surgery on the soft bud, but greater than a time here in this area, sometimes because when you teeth extracted, resorption, greater than a time would be in that area. And another artery and vein and nerve here, we call it nasopalatine artery and vein here in the midline, behind the incisors. And when they extract the teeth, would be, we call it incisive papilla. And this is incisive papilla. This is where the nerve goes out. I've seen books, some people, they do the implant inside, but imagine the nerve is still functioning. Some people, they have vague burning pain. They don't think the dentists think about that nerve before doing the implant inside or damage the nasopalatine nerve. So some dentists, they think because of the corner of the canal is very strong, they use it for engaging the implant, but it can be very painful for the patient. So this is the natural tooth with the root canal. So it's also almost behind the central incisor. And we had the problem with the anterior teeth. We don't have limited space. The buccal plate always resolved. So always they find something to hold their implant to be strong enough to, and we have less damage and less gingival recession after implant insertion. So there are many people, they do avoid it. Some people that avoid this one, nasopalatine canal. Some of them, they use it. And this is the greater palatine. Really great. All this very vascular, and goes across around to the teeth area or residual area. That's greater palatine. This is nasal palatine. It's smaller, but the greater is what they call the greater palatine. And when we have teeth, they're located here. The problem when we lose the teeth, the bone shrinks, and here would be almost near the ridge. So take X-ray, take CBCT, it will be visible when we take CT scan, and you can see it where it's located. Some dentists, they have to measure their knife, but they have to have experience. You can measure your knife and see when you're gonna, you can use the periodontal probe, and you can see where you're gonna put your cut. So this is the teeth. This is gonna be about 3 millimeter or 40 millimeter here away from the teeth. This is attached gingiva, this is alveolar mucosa, and this is greater palatine.
What's the yellow part above? What did you say, the yellow?
This is the teeth.
No, above it.
Attached gingiva. There's attached gingiva, free gingiva, attached gingiva, alveolar mucosa, and here the sometimes some dentists, they take fat graft from the palatine area to support anterior. Sometimes, so just avoid this area. Located here. This is artery, this is the vein. Usually the vein is larger than the artery, but you don't want to get any one of them. So that's what happens. When you have teeth, they are far away. When you don't have teeth, you almost get, because resorption. And look at the sinus. This is the sinus. It's almost gone. It's like sinus. What is this?
The
nasal. This is nasal cavity. This is inferior concha. This is the nasal cavity. So you have to find the location. GPA, greater palatine. This is the sinus, maxillary sinus. Maxillary sinus. In old books, they call them sinus of Heimer. Anyway, so at that time they called it as like they found it, but they didn't find it. They just discovered it, but they just put their name everywhere. The sinus will grow with age, and something it will affect the speech, the resonance of the voice, reduction of the weight of the skull, humidification of air, and many reasons why we have sinuses. But the sinus will grow with age, and most of our patients need implant. They are older, and they extract their teeth, and the sinus will grow back. It will grow faster. Another thing with the sinus, there's remember we said there's mandibular artery and mandibular nerve. There's the maxillary artery and maxillary nerve supply the maxilla. So the one that goes to the teeth has the 3 branches. Posterior superior alveolar nerve.
Okay.
Middle superior alveolar nerve, anterior superior. Posterior superior goes 3rd molar, 2nd molar, and part of the 1st molar. posterior superior, goes in the back. The middle, part of the first molar and 2 premolars, and then the anterior supply the anterior. They can use names, but that's what posterior superior alveolar. It looks loud, but it's the nerve and the artery that supply the back teeth. That's easy. The other thing, it will go inside the sinus. So 20% of cases, they go inside the sinuses. So I have a picture. This one. This. There's many ways to do the sinus lift. One of them, they move the bone a little bit until they see lining. But this is very dangerous sometimes if you're not skilled enough to damage the lining. The lining is very thin of the sinus. So sometimes you find it like there. Like under the bone here, usually we access through the buccal side, and you find it. And it's intraosseous artery. Intraosseous means inside the bone. You don't want to bleeding when you do that. Bleeding will be very dangerous and block your vision. And sometimes the sinus has septi. Septi means partition, not pure. So it's very difficult for some people will fill it with the bone graft. Sometimes there's a trap door. There's many. Maybe we can talk about the surgical option for the sinus. It's almost always in the first molar, premolar, and then the upper area. And there are many authors who talk. They found it very easy if you have, if you're like a radiologist, just see and you have like thousands of doctors send you X-ray. You can study that and you make article or research about how many sinuses has septi, how many sinuses more extended to the premolar, to the canine area. So when you take X-ray, if it's extended to the premolar or the canine area, almost always it's universally or uniformly extend anterior posterior. So if it's extended to the canine area, almost always when it reaches the wisdom tooth, that's when you do extraction of the wisdom teeth, you're careful fracture the tuberous teeth. We had a case, this lady, she tried to kiss a dog. That's the worst thing. Why do you want to kiss a dog? And the dog bit her teeth out. And she lost the anterior teeth this area. And you have to fill bone graft. You can use a mesh. Remember when you can use surgical membrane? Surgical membrane will not hold that. But if you use the titanium mesh and you fill the bone graft, you will have enough bone.
Is that held on with the clamp? The bottom part of it?
We screw it inside.
Oh, okay, I see it.
Yeah, screw it. But for that, you have to be removed after 7 months. But we got enough bone. Because anterior, we need good bone because we're going to lose some bad bone when we do an implant. So, we're just going to get enough bone and look at the difference.
Yeah, that's a big difference.
Yeah. Yep. So we have enough bone for the implant.